Good evening, everyone. I am Ashwani Thakur from the marketing team, and I would like to welcome each one of you for the Paed Connect 2026 in association with IAP. Haleon as a corporate group is known to have a legacy brand which are trusted and recommended by decades, including Crocin, Otrivin, Timinic, and Osteocalcium. Our motto is to deliver everyday health with humanity. We are truly honored to have such a esteemed gathering of pediatric thought leaders with us in the evening. Sincere thanks to Dr. Atanu Bhadra sir and West Bengal Academy of Pediatrics and IAP UK team, Pediatric Academy of Telangana State Chapter. I will play a short corporate video and showcase our product portfolio. Now I would like to invite Dr. Atanu Bhadra sir.
Thank you, Mr. Oshini. And so welcome to this out-of-the-box program. I think this is the first time that two back-to-back PEDICON, the cities that have hosted two back-to-back PEDICONs have joined together again for bringing back the memories. So I fell in deep love with the city of Hyderabad around 2024. That when we started preparing for the PEDICON of Hyderabad. And every event, I did not miss any event, starting from the meeting with the sponsors and different, as the organizers went through the process of organizing this hugely successful PEDICON, I was part of every part of the journey. So we'd start with a short inauguration. There would be no formalities. I would request Dr. Ramesh Dampuri sir, from the TCB, Twin City Branch, the chairperson, president of Twin City Branch, to come to the stage, along with Dr. Vijay Kumar. Vijay Kumar sir, please IA. Dr. Sridhar, and all the faculties, Dr. Nirmala ma'am, Dr. Usha Rani ma'am, Dr. Sapna, Dr. Raghupati, and Dr. Srinivas sir, if he has come, please come to the stage and help us lighting the lamp and start. And I also request Professor Kripasindhu Chatterjee, the president of West Bengal Academy of Pediatrics and one of the main persons of Calcutta PEDICON, to join us on the stage. Dr. Srikant sir, Dr. Srikant, our treasurer of TCB, and please, all the senior persons can join us.
Dr. Krishnamurthy garu, please, and Dr. Jagdish Chandra sir, Dr. Tilak Chandrapal sir, Dr. Ranganath garu, please come onto the dais for the lighting of lamp. And I request Vamshi, please. Alimali madam, please.
Yeah.
No.
So what you saw was actually the galaxy of team that had actually given you that PEDICON at Hyderabad. So I would now request Dr. Enel Sridhar, one of my closest friends, and we are still continuing the journey of the PEDICON. In fact, there was much more continuity. After you see the two presentations, you will find out that many things were common in Hyderabad PEDICON and Calcutta PEDICON. So over to Sridhar to bring back the memories.
Thank you, sir, for your kind words. PDF, yes. Okay. So, good evening, respected dignitaries, senior faculty, my colleagues and friends and members of the Indian Academy of Pediatrics. Thank you very much, Atanapadra sir, to make this PED Connect 2026 in 10 major cities. And out of one, the first your choice is very much appreciable, sir. It's in Hyderabad. And it gives me immense pleasure and deep satisfaction to stand before you today after the grand success of our PEDICON 2025 in this beautiful city of Hyderabad. On behalf of organizing committee and team, as a additional chief organizing secretary of the conference PEDICON 2025, I am Dr. Enel Sridhar, feel truly honored to convey my heartfelt gratitude to and sincere thanks to every individual who made this prestigious conference a memorable and remarkable success. PEDICON 2025 was not merely a conference. It was a celebration of academic excellence, teamwork, friendship, innovation, and spirit of pediatrics. Over the past days, we witnessed outstanding scientific deliberations, inspiring discussions, wonderful networking, and unforgettable moments of togetherness. The overwhelming appreciation from delegates across the country is a testimony to the hard work and dedication of countless people behind the scenes. First and foremost, I express my deepest gratitude to the Central IAP, Indian Academy of Pediatrics, and the PEDICON governing body for entrusting Hyderabad with responsibility of hosting the prestigious national conference. Your confidence in our team motivated us to strive for excellence at every step. We are grateful for your guidance, encouragement, and constant support throughout this journey. Exclusively, my special thanks to all the organizing chairperson, chairmen, organizing secretaries, and advisors, name by name, scientific committee, reception committee, and trade committee, finance committee, hospitality team, transport, and media team, cultural team, trade and exhibition committee, venue management, our volunteers, coordinators, every committee member who worked tirelessly day and night. The success of PEDICON 2025 belongs to each one of you. Behind every successful conference is an army of silent workers whose contributions may not always be visible on stage, but are deeply felt in every smooth session, every smiling delegate, and every perfectly coordinated event. Your commitment, discipline, and passion transform challenges into achievements. I would also like to thank all our esteemed national and international faculty members for sharing their knowledge, experience, and wisdom. A heartfelt thanks to all delegates, postgraduate students, and young pediatricians who participated with great enthusiasm. Your energy and active involvement brought life to PEDICON 2025, and you have seen the success of the conference. The conferences being meaningful only when learning is combined with participation, and all of you made that happen beautifully. I extend sincere gratitude to our industry partners, sponsors, exhibitors, supporters, whose cooperation and partnership played an important role in the successful execution of this mega event. Special thanks to our PCO, Mr. Tirupati Meaty Events, who helped us in making this conference extra mile in the success of the conference. I must also acknowledge the relentless support of our local Pediatric Academy of Telangana State team and also Indian Academy of Pediatrics Twin Cities branch, who had given a good hospitality, warmth, and affection, made every delegate feel at home. Friends, organizing a conference of this magnitude is never the effort of one individual. It is teamwork in the truest sense. It is about the coordination, sacrifice, and shared vision. Really, you can see I will play the video. You can see the efforts of all the organizing team. We had 2 years, more than 2 years, our journey started for 2025 PEDICON. So it is about trust, coordination, sacrifice, and shared vision. And today, as we look back with pride and satisfaction, let us also carry forward the academic spirit, friendships, and memories created during PEDICON 2025. May this conference continue to inspire us to work for better child health, stronger pediatric care, and a brighter future of children across the nation. On behalf of the entire organizing team, I once again offer my sincere thanks to the Indian Academy of Pediatrics and all committees, faculties, delegates, sponsors, volunteers, media partners, and everyone associated with PEDICON 2025. Thank you for your trust and support, your hard work, and your affection. Let us continue to work together with the same spirit and dedication for the advancement of pediatric and child health. Thank you. Jai IAP, Jai Hind. Thank you. Please play the video. Now I request all the academic delegates who had supported us in PEDICON 2025, our committee members, Dr. Nirmala Madam, Usharani Madam, please come on to the dais to watch this video. And along with Krishnamurti Garu, Jagdish Chandra Sir, Ranganath Garu, Tilak Chandrapal Sir, please, Dampuri Sir, Vijay Kumar Garu, please come on to the dais. Vamshi, ikkadi nunchena sare. Play the audio. From start. Audio. Start. Yeah.
Yeah, we need to get our evaluation.
PEDICON 2025 है PEDICON 2020 yes PEDICOन
New President 2025.
Yeah, thank you. Message from, yeah. Total 6 days of event, I made it for 7 minutes. So very short, so many events are there, but major events I had covered and made it 7 minutes. And message from Neil Ramchandar and Surendranath that they are out of station. So they conveyed the wishes to this program. So once again, thank you all the organizing team giving me this opportunity. Thank you one and all. Thank you. Special thanks to Atan Dada.
Thank you. So the memories was relieved. We just went through whatever we are. In fact, we spent almost 8 to 10 days here during that time. And two of the main, one was the PEDICON sports events and another the PEDICON Idol was so successful that it became iconic and it continued over to the next PEDICON. On behalf of PEDICON Kolkata, I thank all of you, hundreds of people who traveled from Telangana, particularly Hyderabad, the faculties, the from our end, we really thank you for traveling to Calcutta during 2026 January and making the follow-up PEDICON of Calcutta successful or as comparable to Hyderabad. Both were, in fact, almost twin PEDICONs. So, and I thank many of the from faculties and Dr. Sridhar and other teams, Dr. Krishnamurthy sir, for again participating in our meetings, giving us advice and everything. I can only say as a national treasurer of IAP during that PEDICON in Hyderabad, I ensured that at least whatever funds has to be released and whatever things, TOT funds that comes from IAP was released very fast. So fast, we can realize now, because till now Calcutta PEDICON has not got its TOT funds from Central IAP. So I think you can realize that it was not automatic. We needed some push there. Yeah. So again, it's a very short video, shorter, I think. you can see it's almost, if you wouldn't have said that it was Calcutta, you would have thought it was almost Hyderabad. So pedicons maintain their continuity. I would now request Professor Kripasindhu Chatterjee, at present the President of the West Bengal Academy of Pediatrics, and the man behind the scientific team which made those 5 days of grueling scientific sessions possible, along with a team. So I would request him to say, make a small presentation on PEDICON.
Thank you, Atanu, and it's my pleasure to be over here to present memories of Kolkata PEDICON in front of all of you. And so far, you have also seen both the videos. I feel this is not Kolkata PEDICON and this is not Hyderabad PEDICON, it is a twin PEDICON. Almost every event I repeated in the same PEDICON every year. Still, I have to present here. Would you be presenting? I'll be presenting from here. So I would just share few slides of West Bengal. Okay. Okay. PEDICON from Kolkata PEDICON, and actually it was, as it happens in all the PEDICONs, it is the most eagerly awaited conferences so far pediatricians are concerned in India, and most widely participated also. Here in Kolkata PEDICON, what I can highlight is that it is an area when science, leadership, our social commitment, our fellowship, our this cultural events all make together to make a single, as a blend of everything came to this conference. And this is one conference which has been recorded by highest number of faculties till date recorded. More than 1700 faculties participated in this conference, and including super specialties and unmatched academic depth. Here I will say about the scientific team later. And it was attended by 9,000 delegates from all over India and also from abroad. And I am sure during that period, a few days happened that patients roamed about from one to another for the pediatricians to search, because all were there in Calcutta. And with folded hands, I express my sincere gratitude that you all presented in Kolkata to make this program successful, and it was your participation that made the program successful. My sincere gratitude for that. It was not an Indian conference per se. It's a globally participated, beyond border conference where the globe actually, Kolkata in particular the venue, it appeared to be a global village. Almost many countries participated. Obviously, the maximum bunch of the faculties came from UK, but many participated, including WHO, UNICEF, and Government of India, to make the program hugely successful. Not only the academics, here also our President Ma'am never left no stone unturned to see, you see, the highest level or the most recent events were also covered. HPV awareness program that is getting launched right now, and that awareness program was launched by our President there in Kolkata also, and it was her brainchild at the same time. Here I have to say, our scientific team did an excellent job. They almost slept, I don't know whether they slept 2 to 3 hours every night or not, but I feel they remained awake for most of the time to make the program hugely successful. My regards to them as well. Now, only academics don't make any program hugely successful. We know for any conference, other than if we stay away from the mic, I'll say you need appetite from the, food from the brain, that is the academics, and you need food for your stomach also, that's the same thing. But here we did something more beyond the academics as well. That is, we thought of the environment as well, and we tried to make it as green a PEDICON as possible. With the environmental work, we go in for tree plantation, we thought of the country as well, and in the community level also, we thought of community participation, like we organized health camps, food support initiative. More than thousands of the children were fed every day during the PEDICON days. And our leadership also thought of social commitments. We do have commitment to our pediatricians, I mean children of our country. Not only that, we need to have the commitment for the society as well. And here is a great initiative that is launched by PEDICON and also the West Bengal Academy of Pediatrics. It's the brainchild of our leadership. A small village where the children have got nothing for their own, as a very downtrodden village, that was taken up, and there we started giving them food for the stomach, there's their nutrition, then food for the brain. We organized, I built now it is already built, a classroom, and there they're getting their academics also, with the teachers have been arranged, and academic materials are also getting. Not only this academics, I mean their study, their clothings, and their nutrition, we thought of that, well, if we can support any community, any village, or any small place, whatever might be, but whether we are doing it enough, is it sufficient for them? So we need quality assessment for that as well. For that quality assessment, now we have engaged our team with the mental experts. They will be going repeatedly to see serial study whether they are improving with our whatever endeavor we are doing. Their nutrition, again regular health checkup will ensure that we are doing the right thing, and also their regular examination would see whether we are doing enough for the academics. We are very much lenient in that way. If it is needed, we can change that, but we'll try to do better for these children. So that is our social commitment. Inauguration, as you all, almost all of you were there during Kolkata PEDICON, you have seen, it was not of the doctors, and all this, most of the part was by the doctors itself, our members did. And all these things came, last point is then is a leadership. So who did all these things? Obviously, there has to be a leader. If you ask me, from West Bengal, I know one leader who is respected all India level at that time was Tapan Kumar Ghosh. And popularly, he used to be called Tapanda in national level. And after that, we have fortunately, we have got another leader there who is all all these programs are brainchild of him. And we are really assisting, we are pawns to that. And I am very much fortunate to be, to get a chance to work under his guidance and supervision. And that is, who is present over here also, Dr. Atanu Bhadra. We hope the same thing would be continued in 2027 Coimbatore PEDICON as well, and Pune 2028. We don't know who is going to host 2029. So let us just have a small clap for our Kolkata PEDICON and Dr. Atanu Bhadra for that. Thank you so much.
Let me invite Dr. Krishnamurthy sir onto the dais, tell about this PEDICON, the song which was created in the PEDICON Idol and the effort. Please, sir.
Sure. Respected seniors of our TCB branch and all my colleagues, and respected past treasurer of IAP, Dr. Atanu Bhadra sir, and president of West Bengal Chapter of IAP, Dr. Chatterjee, and all my youngsters and PGs and the team of Haleon. I'm very much thankful to you for giving me this opportunity, because I would like to just share the happy and hard work moments of pedicons, because always we think this is being a chairman of the cultural committee and this thing, but how much work it requires, I think only the people who involved in that only know it. So I was very much proud to say that I am involved in these activities for the past 16 years, and I did 3 pedicons. I can add one more pedicon of Calcutta also, because I am also part of that. And apart from that, and this thing, but for the past 2025 and 2026, the cultural events was very unique. The cultural programs now achieved a small or bigger space in any pedicons in the future now, because previously we never used to thought about the cultural activities and all. In the people also will talk in the last that what is the cultural activities and what is the cultural community. But now I think it has established its own space, with the thanks to our past treasurer Dr. Athanu Badra sir and past the organizing secretary of the West Bengal Pedicon, because it was the one concept that Pedicon ideal was very highlighted. Of course, it was there 5 to 6 years before, conducted in Mumbai once, but after 6 to 7 years it is abandoned. In 2025, myself and my younger brother and my colleague Dr. N.L. Sridhar, we thought, why don't we have a Pedicon Idol in the All India level on par with the Indian Idol program. Then our humble organizing secretary Dr. Surendranath and the Neeli Ramchandar and all the organizers, they gave a green signal. And it was almost all entire country of our pediatricians participated in that. Eliminated rounds, state rounds, etc., etc. It took 3 months to select the cream 15 people. Similarly, then the organizing secretary of the Calcutta Pedicon, he said definitely we should have, we will encourage it, along with Dr. Vasant Kalatkar and Dr. Athabal. So they taken as a prime aspect of that, and we also announced in a similar way, and they did better than that 2025 of that. Of course, we were the advisors for that. I am very much thankful to you, sir. Now, in the future Pedicon, people will wait for that. The whole country who are passionate to the singing and all, they will wait for the, who will be the Pedicon idol of number 2, number 3, number 4, like that. So it was a thank you very much, sir, for making us to make my dream to come into the true of this Pedicon idol. And another most important, the theme songs. So usually whenever I organize this thing, I am particular about one theme song. We did for our 2025, an evening in Paris, Aaj Aisa Mauka Phir Kahan Milega. Unfortunately, I am not getting that video, so we are not able to present it. So it was involved with all the organizing team, and the song was very fantastic. Then similar way, then we thought, why don't we have a one theme song for this Calcutta Pedicon. So a lot of exercise was done, my dear friend, just you have to, I am just highlighting my experiences, kindly note it down. 3 months it took for us to work for that particular song. Then we thought, why don't we involve the people who are not non-singers also, eminent personalities, past presidents, past secretaries, all what you call stalwarts of our academicians and all. Then he said, okay, done. We have selected the one song that Mile Sur Mera Tumhara, the very popular song of the decade old. Then we made about 33 distinguished delegates or distinguished IAPNs to sing that song for this Pedicon. It was a highlight. So it has become an anthem of IAP, I can say, sir. We can play in the future programs also. I will, without naming them, I think it is not justified to see that song. From Central Zone, the people who have participated in that, Ajay Srivastav, Srilekha Joshi, Akash Lalwani. From North Zone, Jagdish Singh Batra, Marnit Kaur Sodhi, Krisuda Mishra Sen, Dr. Neela Mohan, Dr. Harjit Kaur. From the West Zone, Dr. Upendra Kinjwarkar, Dr. Deepa Parekh, Dr. Nehal Patel, Vasant Kalatkar, Bakul Parekh, Pramod Jog, Swati Bhave, Sangeeta Loda. Then from the east, Purna Ghosh, Dr. Indu Surana, Dr. Santa Chatterjee, Dr. Amit Sinha Mandal, Dr. Bilab Banerjee, Dr. Shamik Sarkar, Dr. Rashnath Das Hazarika, Dr. Atanu Badra sir, Dr. Swapna Ray, and Sushmita Nath. From the south, Dr. N.L. Sridhar, Dr. Krishnamurthy, that's myself, and Dr. Meera Nair, Santosh Sons, Jason D'Souza, Revati Ravishankar, and Ramesh Kumar. So 33, the prominent IAPNs played that song. It's really proud, and I think you might have not watched it during that conference. I request the organizer to play that song for that.
मिले सुर मेरा तुम्हारा ओ सुर बने हमारा सुर की नदियाँ हर दिशा से
It's an original voice of our people, own people, not recorded.
बादलों का रूप लेकर बरसे हल्के हल्के मिले सुर मेरा तुम्हारा तो सुर बने हमारा मिले सुर मेरा तुम्हारा
जाए दर्ज न्याय दर्ज एक बट बनिए साए दर्ज
तेरा सुर मिले मीठे सुर तेरा मिलके बने फिर नवा सुरता मिले सुर मेरा तुम्हारा तो सुर बने हमारा
मुंहिंजो सुर तुंहिंजे सां प्यारा मिले जॾहिं गीत असांजो मधुर तरानो बणे तॾहिं
सुर का दरिया बहते सागर में मिले
बदलादा रूप लेके
बरसन हौले हौले നം ഇരുവരീശ്വരമും നവതാരം ദേശവേദാനാലും ആഴിശേ ആലുകൾ മുകിലായി മഴയായി പൊഴിവത് പോൽ ഇസൈ നമ്മിസൈ
ನಿಮ್ಮ ಧ್ವನಿಗೆ ನಿಮ್ಮ ಧ್ವನಿಯ ಸೇರಿದಂತೆ ನಮ್ಮ ಧ್ವನಿಯ
എന്റെ സ്വരവും നിങ്ങളുടെ സ്വരവും ഒത്തുചേർന്ന് നമ്മുടെ സ്വരമാ তোমার সুর মোদের সুর সৃষ্টি করো ওই সুর
তোমার সুর মোদের সুর সৃষ্টি করু ওই সুর
সৃষ্টি করো ওই কথা তোমার মোর স্বরর মিলন সৃষ্টি করি চলুব চতন
મારે સૂર જો તારો મારો બને આપણો સૂર નિરાળો
माझ्या तुमच्या जुता तर मधुर सुरांच्या बरसते धारा सुर की नदी
Thank you. But lastly, I would like to mention that the concept and the theme of course, myself and Dr. N.L. Sridhar, but the hard work is done by none other than the organizing secretary of the past treasurer, my brother, Dr. Athanubhadra. With love and affection towards him, all dignitaries participated in that. Thank you very much.
Thank you. No, it was his brainchild, so we only executed it. I think we have Dr. Bhaskar sir. Funds are the most important thing, and I think being a treasurer, I know what importance it is. So, treasurer to treasurer, sir, few words.
Good evening and namaskars. At the outset, I thank Dr. Athan Badra and West Bengal Academy of Pediatrics, UK branch IAP, and as well Haleon. It's looking like Thanksgiving and as well appreciating both the conferences, and probably this kind of organization, first of its kind, to do it, and forwarding whatever academic achievements you had at Kolkata and we had at Hyderabad should be spread across India. So as a treasurer, ever since our conference was allotted to Hyderabad, so first 3 months we were focusing on registrations. Since our motto is 30% of the conference expenditure should come from the delegates registration. So we started working from 2023 October, I believe. We had good number of registrations. Then we were a little happy. After 3 months, we were again tensed up because a lot of MCA rules and regulations, Health Ministry rules and regulations. Some of our colleagues had circulated a mail which went on up to Prime Minister, Health Ministry, Director. We thought we will not get funds. Until June, no pharma was coming to us. We were afraid. We had booked in a best of the best venues at Hyderabad, which was costing, Dr. Sridhar knows better than me, it was costing more than 2 crores, I believe, 2 or 3 crores for our venues. No money. And from July onwards, 1 or 2 companies had come forward, started giving us money, but we were really restless. Last 3 months, there was a flood of pharma companies approaching us, and they had given us sufficient funds. And all these 12 months, we had ran our office in 6 feet by 6 feet, 6 feet by 6 feet room with a core committee of 25 members. Once in a while, we used to do in nearby relatively budget hotels like Hotel Plaza. And all the decisions regarding the budget expenditure were taken by the committees, were approved by the committees, and then we moved forward. So I'm very proud to say, though our treasurer, our secretary, they were all behind us to send money as and when we were getting delegates' money, they were reminding us. So we used to spend. Dr. Athan Badra was giving us some space and time, unlike other person in that central IAP. I'm very proud to say our surplus was more than 3 crores. That would be distributed at a later date, but we have more than 3 crores of surplus. So all these happened because of the core committee, because of the committee members, because of all the IAP members of Telangana state, and with the cooperation of the central IAP. So I'm thankful to all, and whatever success we had seen, it was due to your contribution, your cooperation, and your efforts. So once again, I thank Dr. Athan Badra. Probably he had chosen Hyderabad as its first first program to be commenced. I wish this program all the very best. Thank you, sir. Thank you very much. Jai Hind.
So before we start the scientific component, you can see this is a joint program with IAP UK branch. During the presidency of Dr. Ramesh Kumar and Dr. Bakul Parekh, before that, there was a new committee formed. Dr. Ramesh Kumar called me up. He said that you are in many committees of IAP. There is some restriction, so I cannot put you in any of the committees, but I will put you in charge of a new committee. And that, I know, sir, what is the name of that committee? He said, Beyond Borders Committee. I know, sir, what is that? Well, you have to start branches outside the country. I know, sir, has anyone done it before this? Well, no, that's why it's with you. So we started work from around 3-4 years ago, and finally 2 or 3 branches came up, but the most active branches turned out to be IAP UK branch. So today this is a joint program with IAP UK actually. So I would request Dr. Bhivan Shah, who is in charge of IAP UK branch, who has inspired and made the organization viable there in UK. And all our doctors, IAP members are part of it now. So Dr. Bhivan, I would request you to say a few words to the audience about IAP UK.
Thank you, Atanuda. Am I audible?
Yeah, you are.
Okay, thank you, Atanuda. I think it is quite late, nearly 9 o'clock in India at the moment. While I'm outside actually going to a cricket match because it is one of those weekends where we have seen some sun for the first time in UK this summer. So I'm traveling as well. So I took this time to, I think this is a fantastic podium to say that the least I could say for IIP PEDICON Hyderabad and IIP PEDICON Kolkata back-to-back 2025 and 2026. I think this is probably a venture that we had dreamt of, and it is coming into light with the hiring and endeavor of none other than Dr. Bhadra, who is in front of us. He's my senior dada actually. And I think IIP UK has done quite good in the last 2 years. It came into force, and with the support of our parent body, we've got about 38 members at the moment, and we are doing a regular interactive educational as well as recruitment, where we have got an international fellowship program. We've tied hands with IIP UK with IIP India, and we have done a overseas fellowship program. IIP formally signed it last year, and we have now got about 5 fellows last year and 3 fellows who come on a 2-year elective program in UK, fully paid fellowship, and they train in the UK, and then they go on either they go back to the country or go on to with their further studies, whatever they want. And when in doing this, probably we have blended more with the IIP organization. We had about 11 delegates going to IIP PEDICON Kolkata, where it was something flamboyant that we saw, and none but not the least, I have to say that Dr. Sridhar, who's my very good friend, and we always meet on the cricket field when we play for, I play for West Bengal and he plays for Hyderabad, and we have a good banter and laugh there. I just wanted to finish by saying that nothing is bigger than the organization. As Kripada correctly said, Tapun Ghosh, he was a figure, and he has passed on his legacy, which Atanuda is carrying. I mean, people will come and people will go. When Sunil Gavaskar left, we thought we will not have anyone else like him. And then Sachin Tendulkar came in. He left. Virat Kohli came in. And now Virat Kohli is leaving. We've got Vaibhav Sudhavamshi. So the post is a chair. What is important is India. What is important is IIP. And what is important is organization. So long live IIP UK and long live IIP. Thank you.
Thank you, Bhivan. So I would now request Dr. Ramesh Dampuri sir, who has taken the full load of the scientific program. So Ramesh sir, over to you, sir.
evening all. Sorry we are late for different reasons, but we will finish off in another 1 hour. So first we have first we thought of panel discussion, but because of some time reasons, we have first talk from the UK, Dr. Snehit Reddy Kasu. He is in Manchester, UK, and he talks on infections and endocrine, common pitfalls in the practice. So he'll be talking on the infections and endocrines before screen comes. And this is in association with West Bengal, IAPTCB PATS and UK Manchester, UK branch of IAP. We are doing this program. I must thank Atnu and West Bengal Pediatrics for giving the opportunity for IAPTCB branch. So, is it there? It's coming.
Hi, Dr. Ramesh. Good evening. I'm here.
Okay.
I hope
Right? Are you
my
ready?
screen is visible. My slides are ready and visible.
Right. Is he audible? Right. So, Dr. Snehit, please.
Yeah. Thank you, IAP West Bengal, Dr. Atanu sir, and IAP UK, Dr. Bivan, who is one of my mentors, and then IAP Twin Cities branch and IAP of Telangana State for giving me this opportunity. So today I would like to go ahead with my topic, which is pediatric endocrinology and infections. And I would like to go ahead with the common pitfalls that all the general pediatricians, as a general pediatrician, what we encounter. So going into the topic, I would like to divide my session into under all of these. And as we go ahead, you will know how and what the importance of each is. And so first, why this topic matters. So endocrine emergencies, they do mimic sepsis in many ways, like adrenal crisis, thyroid storm, or decay. Most of them, they have similar presentations like fever, tachycardia, vomiting. So you should always keep things in your mind before going ahead with management. And second thing, the infections, they do destabilize endocrine conditions. So that is one reason that this topic is very interesting. And last but not the least, steroids are one of the most used drugs, but they are least understood. So steroids, in whichever route, they do play a very important role in the hormonal balance, and then using them wisely matters a lot. And as a general pediatricians, we are the first responders, and recognizing these would be very important. So, I would like to bring to your notice that everyone can think in terms of endocrinologist, only ones we do slightly alter in our practice. Like we do usually measures high weights in our practice, but I would also like to inform you that measuring height matters is very important, especially with endocrine. So having a stereometer and also an infantometer in your practice would be very important. So growth pattern and trend matters the most, and faltering growth or accelerating BMI, these are all very good indicators pointing towards some endocrine cause. So I've just put in, like, now there is no paper, everything is app. So there are some apps on even Play Store where you can get growth chart plotter and stuff. And I've just put in a screenshot of, if you can just enter the thing, the whole app does everything for you. It will show you where your centiles are, what is the BMI of the kid, and this is very important. And if you have records of the kid, they can be continuously monitored, and you know how the kid is growing and also stuff. So apart from, I'm not talking about hi-fi investigations in endocrine. It's all basic investigations like blood glucose, urine dip, which can be done at point of care, and blood ketones, all of these, and blood gas and electrolytes, where we have even point of care blood gas and electrolytes, and the basic thyroid functions. So all of these investigations point out towards something very important in infection and endocrine. So considering all of these is very important whenever you do. So and just not ordering an investigation, but interpretation of investigation and knowing what the background is matters a lot. So was the child acutely unwell? So these orders, all these investigations, the hormones, all of these alter a lot based upon the condition and stuff. So fasting, non-fasting, timing of collection, and all of these matters a lot. And some simple things like, was it I mean, if there was an IV infusion running nearby, even then the values can get altered. And some simple values like, see, like vitamin D, if it is, I mean, it is, so if the values matter a lot. So nanogram per ml, it's only 12, but nanomole per liter is 30. So you need to keep in mind while seeing the reports, all of these. Yeah. And always, last but not the least, does the child's result fit in with the clinical picture? If not, try and repeat the sample and see. So it's more or less the same, this slide, the one that I've talked earlier, especially with thyroid. During acute illness, body tries to, I mean, play fairly. So it tries to conserve energy. So the free T3, which is the most active, the value might be low during acute illness. So this is called sick euthyroid or sick, I mean, the values can vary. So considering the clinical picture, thinking a lot, and before ordering and interpreting investigation matters a lot. Okay. So coming with the first bit, so with the endocrine infection interface, I would like to first deal with the hypothalamic pituitary axis, where hypothalamus, pituitary, and adrenal, all the three play a very important role in maintaining the cortisol levels in the body. So coming to the cortisol, which is a stress hormone. So a functioning hypothalamic pituitary axis is very essential for survival of any serious illness, because cortisol maintains the vascular tone and it also regulates glucose availability, it modulates inflammatory response. There's a lot of things which cortisol does. So here I've just shown you the variation in baseline cortisol depending upon how high the stress is or what different stresses can cause. So if it is a baseline level is there, and with minor illness or fever, it gets 3x. This is all roughly what happens. So just an indication of how high it can go, just to tolerate the stress that body is undergoing. So if you see, during sepsis, it can go up to 8 to 10 times the baseline. But a child with adrenal insufficiency cannot mount this response. So because of which they can land in shock. So it's very important. So there are various causes of adrenal insufficiency. So out of all of this, like congenital adrenal hypoplasia is one thing that we frequently encounter. Considering the Indian setting, so we need to always think of tuberculosis and infections like meningococcal septicemia. Full-blown can cause Waterhouse-Friderichsen syndrome, where which can cause adrenal insufficiency. And in the same way, high-dose glucocorticoid therapy, so irrational use of steroids can suppress the HPA axis and then cause tertiary adrenal insufficiency. So keeping in mind all of this is very important. And how to recognize the adrenal crisis. So they can present with hypotension, tachycardia, shock, which can happen like in any septic shock or anything also. So keeping in mind of the metabolic abnormalities which we frequently encounter, like hyponatremia, hypokalemia, and hypoglycemia, along with metabolic acidosis, which is most commonly seen. This setting always reminds us about the adrenal crisis. And they can be lethargic, confused, and seizures can be seen if they are hypoglycemic. And coming to physical features, always remember the hyperpigmentation which can occur due to high ACTH, which is coming from the above to stimulate cortisol secretion. So this can stimulate the melanocyte receptors, and then this can cause hyperpigmentation. I've got some pictures which you can see here. So the first picture is a child with a female which looks apparently male from far, but as you go clearly and go cleanly observe, then you can see that the labia are fused. And the second picture, you can see a child with hyperpigmentation, see the lips and stuff, where you can see the hyperpigmentation, which can be seen in adrenal insufficiency. And the third picture, you can see the glass test, which we commonly tell patients in UK, where they try and compress and see, so which can be seen in meningococcal septicemia, where there is non-blanching rash. So, and you can see the difference between the hyperpigmented child with adrenal insufficiency here on the right, and after treatment with steroids, you see how the variation in pigmentation. So it's very important to recognize these physical features in identifying. So the emergency management is the same, where you usually, whatever you do, the fluids and everything, but only thing, always consider hydrocortisone IV to be given. in a child with adrenal insufficiency. And the hypoglycemia should be treated with 10% dextrose. So always consider this IV hydrocortisone whenever you suspect any child having adrenal insufficiency, which will present with overlapping symptoms of sepsis, who have got metabolic abnormalities that I have told, hyponatremia, hypokalemia, hypoglycemia, and shock and sepsis. Yeah. So it's very important, this one, because septic shock, all these conditions that you can see, septic shock, adrenal crisis, thyroid storm, DKA and sepsis, congenital adrenal hypoplasia, salt wasting, and Waterhouse Fredrickson, all of this, they almost have similar presentation, but recognizing the condition is very important. So going ahead, we can see some of these, and I'll let you know how to deal with. So coming to the second subset of this talk, where is infection in children with diabetes. So the care of a child with diabetes, there are many new upcoming things like smart pens, CGM, which you can see in this picture clearly depicted. Earlier, it was multi-dose injection with insulin, but now there are insulin pumps, many things coming up. So as we go ahead, I'll talk you through what is coming to the pathophysiology of infections in diabetes. So the main thing which can happen is, so a kid with diabetes will have hyperglycemia, glucosuria, so they are more prone to infections compared to others, and medical intervention. So frequent monitoring of blood glucose, either through pricks, encountering healthcare staff, they can, I mean, like nurses, doctors, whatever, they can get exposed to hospital-acquired infections there. And there is also a component of decreased immunity in them to decrease antioxidant system, decrease neutrophil functions, etc., which can make them prone to infections. So the most common infections in a child with diabetes mellitus, like respiratory tract infections, can be seen, especially in Indian setting. Tuberculosis should be considered, and they are prone to high risk. They are prone to, and influenza, which is frequently encountered. Skin and soft tissue infections, which we can see UTIs because of the glucosuria, and periodontal infections, infections of the oral cavities and stuff. And some life-threatening infections like mucormycosis, which happened especially during COVID, where most of them were treated with steroids and then had high blood sugars. So always consider all of these infections in a child with diabetes, always. So here are some pictures where there's periodontitis in this child, which you can see the red gums of the lower gum. And then there you can see on the other picture where there are skin lesions in this child with hidradenitis suppurativa, so which is infected pustules. And the organisms, they can be bacterial, fungal, viral, everything. So bacterial Staph aureus is most common, especially with new pumps and new bacterial pumps. So this can cause pump site abscesses and stuff. And in fungal infections, especially vulvovaginal candidiasis in females and stuff, need to be considered, and it's very important. And viral, including COVID, influenza, all these infections are common in a child with their diabetes. So DKA and infections, this is a very dangerous bidirectional relationship. So why infection itself can trigger DKA? So physiological stress causes high hormones like cortisol, glucagon, which can lead to high blood sugars. And these counter-regulatory hormones also increase and cause high blood sugars. And then, so there is already it's an insulin deficiency state. So then they are prone to lipolysis, ketogenesis, and all of these infections in turn can go together and then cause infection in a child with background diabetes who presents with DKA. So new onset type 1 diabetes mellitus can present with DKA and infection simultaneously. And the cornerstone of prevention should be good glycemic control, adherence to vaccination programs, which I know IAP also recommends annual influenza vaccine in children with diabetes. So emphasis on that is very important. And the other thing is sick day management. All the children with diabetes should be encouraged and should be taught about the sick day management. And that plays a very important role so that they don't land in DKA. Sorry, I'm being a bit quick, because we are short of time. And coming to the other infections and thyroid disorders in children, my next topic. So where I would like to emphasize this point again and again, history and clinical examination will play a very important role, because there are a lot of overlapping symptoms in this and clinical signs also. So thyroid storm, we usually don't see this. It's mostly in adults and adolescents where they have this symptoms like fever, very high grade fever, tachycardia disproportionate to fever, and extreme agitation and tremors. And you can see a goiter in a child, and also this exophthalmos. So this is most commonly seen in adolescents and adults. So here are some pictures where you can see a goiter and exophthalmos. So exophthalmos where they have this prominent eyes. So these are the clinical signs that you need to look for, because thyroid storm also presents with very like similar picture to sepsis, where they have fever, everything, tachycardia, everything. So recognizing clinical signs is very important. That is why I've just put in these pictures. And if you can see this picture, the other end of this age also can have some of the features. So if someone can just see and comment on this picture, I'll be quick. So these twins, they demonstrate clinical features of neonatal hypothyroidism or thyrotoxicosis. They have this anxious appearing stare and diminished subcutaneous fat, and they are irritable, if you can see the picture. So if mother is on antithyroid drugs and has been, or there is history of Graves' disease where she has got the antibodies, the TSH receptor stimulating antibodies, which can be passed on to the neonates, they can have these features of hypothyroidism. So in that age, so tachycardia, irritability, we think about sepsis, so which can be overlapping again. So you will need to be very, very good with your history and clinical examination in order to differentiate. And neonates can present with subtle signs of poor feeding, poor weight gain, irritability, jitteriness, like we have seen in the picture, and tachycardia, tachypnea, all these can be seen. And so even intrauterine, the fetus can show this. So with the advancing fetal medicine and scans and everything, even they can recognize it while the baby is in utero. So fetal hypothyroidism signs can be seen. So asking about the scans and asking about the history and clinical examination is very important. And in the same way, hypothyroidism, so you can see the child will be short for age, will be puffy, might have goiter, and there can be history of constipation. If it's an adolescent, there can be irregular periods. So this picture is a brief overview of various symptoms that we can encounter in hypothyroidism. So the same way, the other spectrum of age where they have this, because it's not, we don't have universal newborn thyroid screening as of now, but most of the hospitals do that. So children with hypothyroid can be missed. So they can have these subtle signs of hypotonia, abdominal distension, umbilical hernia, prominent tongue, and jaundice and all of this stuff. So this picture shows us that bit. So hypothyroid and infections, because thyroid plays a very important role. So it's like one of the master hormones in our body. So that can cause hypothyroidism. Children with hypothyroidism are prone to more infections in many ways, like reduced immune efficiency, reduced gut motility, poor overall growth and nutrition, and everything. So in the table below, I've shown fatigue and lethargy in a child with hypothyroid can also be seen in child with infection. So it's very important to know the history and clinical examination. Like hypothermia also can be seen in severe sepsis. Puffy face and ill appearance can be seen. So there are overlap of a lot of symptoms. So you should always have a good history, clinical examination before going ahead and treating the child. And they can commonly have infections with recurrent URTIs, otitis media, pneumonia. Because of the dry skin, even skin infections are most common, and constipation there can be association with enteric infections. So these are very important overlap. So coming to the next bit, this is steroids and infections in children. So if you can see, there is a picture of a child here, my story. This is a 9-month-old. I'll tell you a story of this kid. So this is a 9-month-old kid who had some fungal infection or rash on the tummy. So this mom went to the some pharmacist, and she told that she wanted a cream for this rash of this baby. So pharmacist gave mom clobetasol cream. She started applying this. 1 week, Symptoms slightly decreased, so she felt this child was improving. She continued for around 6 months, and then baby landed this way. So the abuse of over-the-counter medications by most of the parents, because there's no consultation fee required. The pharmacist is easily giving them, so they're just trying and seeing. But then ultimately, baby had full-blown Cushingoid features with puffy cheeks and everything. So next bit is very important, and I would like to emphasize on this part. So if you see the potency of steroids, various steroids, hydrocortisone is almost equal to cortisol. So it's 1x potent with the glucocorticoid potency. And if you can see here, and then the prednisolone is 4 times more potent. Methylprednisolone is 5 times more potent than hydrocortisone. Dexamethasone, which is one of the most frequently used steroids, it's 25 to 30 times more potent than hydrocortisone. And fludrocortisone is the mineralocorticoid. So always keep this table in mind before prescribing any steroid to a child. So hydrocortisone is the least potent steroid. So so always keep in mind, in case some conditions might require steroid, so don't go ahead and give dexamethasone. That is very, very potent. So I would like to you all to consider and keep this table in your mind before going ahead and prescribing a steroid to a child. Okay. So this table indicates that. And so with regard to hypothalamic pituitary adrenal axis suppression after treating a child with steroid. So there are medical conditions like nephrotic, where we start the child on prednisolone for around 6 weeks, 2 mg per kg per day, and also like neurotuberculosis, where they are all on steroids and stuff. So all these children will be, if you evaluate them, they do have this HPA axis suppression. So exposure of prednisolone more than 2 mg per kg per day for 2 weeks, and hydrocortisone, which is the least potent steroid, 10 mg per meter square if you calculate the BSA&C, for more than 4 weeks. All these can cause suppression of HPA axis. And last but not the least, even inhaled corticosteroids like fluticasone can suppress with long-term use. And topical steroid, like I've told you, the story of that kid that we saw earlier on the picture. So it was a topical steroid, but then it did cause full-blown Cushingoid appearance. So always keep in mind about HPA axis suppression and before prescribing any steroid to a child. Okay. So, and these are the sick day rules. Any child who has had or was treated with steroid and you think they are Cushingoid in appearance or might have HPA axis suppression because of the duration of steroids that they were on. So you should always encourage the child and the parents about the sick day rules that they need to follow. I know oral hydrocortisone is not that easily available in India, but it is still available. So oral hydrocortisone should be prescribed for all those children who you feel that their HPA axis is suppressed. So with regard to what stress they are undergoing, so like moderate illness, they might need 30 mg per meter square per day. So calculating body surface area is very important. And so severe illness, they might require 50 mg per meter square. And very severe illness might require 100 mg per meter square per day. So, and it can be IM in case if they are very sick and they're not accepting. And all the parents, and if they are bigger children, they should be taught about this sick day rules, and written plan should be given to them. And so steroids themselves can cause immunosuppression, and there is masking of infection. So the symptoms, so they might not be full-blown fever response like in a normal child with a child on steroids. So you need to be very careful and be proactive in treating them in case if they have even subtle signs of sepsis or infection. And there can be misleading WBC count. Seeing this, the full blood count of a child with steroid, you might feel there is like high WBC count, but it's because the neutrophil demargination in them is less compared to a normal child. So that is why you can have apparently high WBC counts. So even surgical emergencies, they might not have full-blown picture like in usual child. So you need to be very careful. And opportunistic organism risk, especially with children undergoing chemotherapy and steroids in their treatment, like in ALL, maintenance therapies or stuff. So they are also prone to like opportunistic infections like pneumocystis jirovecii pneumonia. And they are also prone to varicella, which is where we commonly see in chickenpox. and some fungal infections like Candida. So always keep in mind a child who has had steroids need to be very careful, and you need to think about if their HbA axis is suppressed. And last, child with excess weight and infection. So this child with excess weight, I feel I've deliberately not included obesity because people do recognize, and children in these days, they do get offended if you tell them they're obese. So this term in UK, I feel like they use it more frequently than obesity. So child with excess weight and infections. So obesity is one of the most common nutritional disorder in children in worldwide with serious endocrine and infectious consequences. So this is one very important thing. So especially if you see a child, how do you feel? How do you know that this child is obese? So only once you plot his BMI where they are more than 85th centile for age, then it's overweight, and more than 95th centile, they are obese. So that is why plotting growth is very important nowadays. And then, so in an obese child, you must see about these physical manifestations like acanthosis, where you can see in the picture there, the dark velvety thickened skin in the nape of the neck, axil, or groin. And then always measure the waist circumference from the lowest point of the ribs to the highest point on iliac crest, the midpoint between those. So where you can check the waist circumference, and we have got centiles for that also. And it is they are available on the ISPE website, on the IAP website also, where if the waist circumference is more than 90th centile, then it's a marker for central adiposity. And always check blood pressure, and blood pressure is more than 90th centile for height and age is elevated. So while checking blood pressure, we usually use the AAP and guidelines which are based on height, where depending upon the height of the child, they have got centiles. So more than 95th centile is stage 1 hypertension and stuff. So always check blood pressure in an obese child whenever you suspect obesity. And some bloods which can tell about insulin resistance, like high fasting insulin, or this thing called HOMA-IR index, which is fasting insulin and fasting glucose divided by 22.5. If it's more than 2.5, then that is also a suggestion of insulin resistance. And dyslipidemia on bloods that needs to be checked, especially in all obese children. So where you can have high triglycerides and low HDL. And raised ALT is also a sign of MASH, which is a new term where metabolic dysfunction associated steatohepatitis instead of non-alcoholic fatty liver disease, which was the earlier. Now we have got this MASH, a new term. And always check vitamin D status in a child with obesity, and especially in adolescent females. So PCOS, new name for it is polyendocrine metabolic ovarian syndrome. In adolescent girls, they can have symptoms of oligomenorrhea, hirsutism, and acne, etc. So obesity and infections, so the same way. So obese children have a lot of immune dysregulation, where they can have background chronic low-grade inflammation. And then there is also a component of respiratory compromise because of thick abdominal fat, so which can cause reduced functional residual capacity. And then they are more prone to LRTIs, or the severity of LRTI in them is much more compared to a normal child. And because of the warm, moist skin folds, they are prone to skin and soft tissue infections, and like intertrigo, and also some candidal skin infections. And especially with infections in obesity, antibiotic dosing, you need to use actual body weight, but not more than adult dose while calculating the antibiotics. And steroids, use wisely steroids in a child with obesity, because they are already prone to background hypoglycemia, type 2 diabetes and stuff. So you need to be very careful. And last topic, infections and areate search, and which is syndrome of inappropriate areate secretion. So infections themselves can stimulate the hypothalamus releasing ADH, and pain, and all of these children who are sick, they do have, that itself acts as a stimulus for areate secretion. And background illness like respiratory disease or meningitis, all these infections, they do stimulate ADH release. And above this, if a child is given hypotonic fluids, then they might land in hyponatremia and might show full-blown seizures and stuff. So Unexplained hyponatremia with normovolemia is commonly seen in SADH, and history again is very important here. Most of the infections, metabolic conditions, and drugs, anti-epileptics in history should be asked, especially in a child with seizures. So carbamazepine can cause, and in a child with chemotherapy, vincristine can cause. So you need to look for the symptoms. Mild, there might not be any symptoms, signs or symptoms, but then severe can show signs of cerebral edema and seizures. So coming to bloods, you need to check paired samples for both in the urine and serum, where you need to check osmolality, glucose, and electrolytes. And always check baseline thyroid function and cortisol and kidney functions in a child with SADH, because cortisol and thyroid hormones themselves, if they are low, can lead to similar features of hyponatremia and similar features. So that is why I always check baseline. And the management will be just fluid restriction, which is very easy. And so always any child admitted, especially if they are sick in ICU setting, they always will be started on 70% of maintenance mostly. And then if they are symptomatic with seizures, you need to consider 3% NaCl. But always, while correcting hyponatremia, keep in mind that the storm shouldn't be corrected quickly, and it should be maximum of 12 to 15 millimole per liter in a. So coming to the end, red flags, hyponatremia, hypokalemia, and shock. Hyperkalemia and shock, always keep adrenal crisis in your mind and always give hydrocortisone. And fever, purpuric rash, and hemodynamic collapse, especially in case if there's a non-blanching rash and some exposure to meningococcal in history in a class or whatever. So Waterhouse Fredrickson, which can cause this full-blown meningococcal sepsis, can cause adrenal insufficiency, where you need to treat with both antibiotics and steroid. High fever, tachycardia out of proportion, background known thyroid disease, always consider thyroid storm and in your mind. And neonate day 5 to 14, ambiguous genitalia, vomiting, shock, no obvious reason, then CH, salt wasting crisis, need to be kept in mind. So the treatment will be again salt, replacement of salt, IV fluids, hydrocortisone, and correcting hypoglycemia with 10% X-dose. Child on steroids and fever with normal WBC, always keep in mind WBC count is very unreliable. Full sepsis workup should be done, and you should have low threshold for antibiotics. Type 1 diabetes mellitus child with vomiting, fever, and sick child. So DKA can be triggered with infection. So never stop in insulin. Treat with antibiotic cover, consider antibiotics also, and continue to check ketones and ensure they are hydrated. If they are in DKA, you need to start the full-blown DKA management. Infections and hyponatremia, SADH should be kept in mind. Do not give hypotonic fluids, restrict total fluid intake, and treat if they are symptomatic with 3% NaCl. Obese child, always keep in mind they are prone to more infections. So you need to check their vitamin D status and think twice before giving steroids, and only give if it's very necessary. And always monitor and screen for insulin resistance, and they might have subtle symptoms or signs of insulin resistance like acanthosis nigricans and stuff. Okay, thank you. And these are my take-home messages. Make your clinic endocrine friendly with simple measures like having stereometer, infantometer, doing some baseline blood tests whenever you suspect to have a child to have some endocrine condition. Interpreting labs is very important. The number alone doesn't mean context, timing, collection, and transport. Everything plays a very important role. And I always, like I told many times, history and clinical examination play a very important role in children with infections and endocrine. And think twice before prescribing steroid, the dose and duration. And hydrocortisone should be kept in mind because this is the least potent steroid. Even topical hydrocortisone is available. So instead of prescribing clobetasol, try and prescribe the least potent steroid and use rationally the steroids. Educating parents and children on stress dosing of steroids saves life. It's very important. And children with excess weight, try and use this term more commonly, and they should be recognized and referred appropriately to an endocrinologist after basic workup, considering if they have signs of insulin resistance and stuff. And think SIADH with severe infections. Thank you. Thank you so much. I've got a quiz at the end, but then we are short of time, so I'm not going to play that. Thank you so much.
Thank you, Dr. Sneh, for an excellent talk on the infections and endocrine, a common pitfalls, which we usually made in office practice. Thank you very much. And now we go to the next session. That is the most common thing which we see in our office practice. Fever management in office practice. We have a panel discussion led by moderator Dr. Usharani. I invite the panelist Dr. Nirmala. She is a professor at Bonagiri, and we have neonatologist Dr. Swapna and also intensivist Dr. Raghupati. So for this, Dr. Usharani will be moderating. She is a ADME and Superintendent Nagar Karnool Hospital and former Superintendent, and she is also President-elect of TCB IAP. Welcome, madam.
Yeah. Very good evening to you all. Thank you organizers for this opportunity. Dr. Atanu Badra sir and Dr. Sridhar, they have presented exhilarating, and also their teams, they have exhilarating and very vibrant memories of the two PEDICONs. I'm sure all of you are warmed up, but we have to go back to the business of fever in office practice. The three panelists, Nirmala is a senior professor of pediatrics, intensivist Dr. Raghupati, and also neonatologist Dr. Swapna is there. So fever, it is a commonest symptom which we come across in pediatric practice is fever. And most of the cases of fever are self-limiting, and we can manage them well in a simple manner. But a significant proportion of the cases of fever are sometimes enigmatic. In spite of vast experience, decades of experience, we do get some bouncers while treating fever cases. I would like to share a case which I have seen recently. A child who is 3-year-old came with high-grade fever of 2 days duration. Then no other symptoms. Child is not very well looking, neither very sick. I was thinking whether to wait and watch or to send some urine examination, but when we undressed the child and saw, this kind of rash was there. So this 3-year-old child, it's so unusual child, did not have any pruritus or burning sensation, so parents did not complain. They thought it is some heat rash, and they were not complaining about this. But when I explored the history, this child had chicken pox at the age of 3 months from the elder sibling. So this is a classic case of herpes zoster, but we very rarely see in a young child. And that too, high fever is not so common. In herpes zoster in a child is so mild, only rash with little symptoms. So if you look in whenever a child comes to us, we all know we need to triage the case based on the severity. If the child is well, in green zone, we just treat and send them home. If the child is moderately sick, yellow zone, we need to closely follow up. If there are red flags, we need to admit and treat. But if you see the prescriptions, there are so many irrational practices prevalent. So a battery of investigations are done. In a nearby nursing home, I observed every day fever profile is done till the fever subsides. Every day Vidal is done, every day malaria smear is done. So and similarly, lot of combinations of antibiotics and also antibiotics, unnecessarily even for mild fevers, antibiotics are given. Injectable paracetamol is given. So we need to manage the fevers rationally, because most of the fevers in children in office practice are simple and self-limiting. And we have our esteemed panelists to tell us how to manage these fevers rationally. We'll start with Dr. Nirmala. This is a case which every one of us come across and in day-to-day practice. This is a 4-year-old female child. Comes to you with fever of 2 days duration. What do you do, Nirmala, when a child comes to you like this? What kind of history, how do you evaluate the child?
Good evening, everybody. Whenever we come across a child with fever, which is a common complaint we see in the outpatient and in the clinics, so we need to see, one is the age of the child and whether the child is active or not, and what are the associated symptoms. So based on the history, the most common cause of fevers in children are the viral infections. So based on the age is one, and also you need to differentiate viral from bacterial infections, and also the whether the baby is sick looking or well looking. So whenever the febrile well looking child, usually you often think about the viral infections, and then the child is playful, active, accepting feeds, you just give counsel the parents and to come back after 24 to 48 hours and telling them the red flags. If the baby is sick looking, and particularly if the child is an infant or a neonate, you should be very cautious and take care of the child. And two common scenarios which we see is the viral infections, which usually have a systemic, multi-system involvement, where the child may have eye congestion, throat congestion, as well as myalgias, in comparison to bacterial infections, where it is commonly seen localized.
Such a finding is seen in the throat examination. What would be the?
Yeah, this is commonly we see in the viral infections, where the throat pharyngoconjunctival fevers are common, and also we often see the there are ulcers over the fauces, the child presenting with fever and throat pain. Look at the same time the eyes, whether there is associated conjunctivitis. So during certain episodes of pharyngoconjunctival fevers, we commonly see. Then the second case, the tongue, we often see during hand, foot, mouth disease, which commonly are seen. So always look for the presence of vascular rash on the palms and soles, and ulcers in the throat. Sometimes they get confused with the presence of vesicles as varicella. So it is not varicella. You always need to differentiate the presentation.
There is a membrane in the throat. Is it always bacterial?
So the membrane in the throat is, one is the bacterial, which the streptococcal infections or the diphtheria, but not all membranes are due to bacteria.
Yes, as rightly said, even we have seen a case of infectious mononucleosis. The child presented with severe throat pain, high-grade fever. Within 24 hours, the tonsillar swelling as well as the membrane increased, and also there was lymphadenopathy. Actually, I thought it's diphtheria, but the membrane did not cross beyond the fascial line. So that turned out to be EBV. The EBV serology was positive for that case. And many a times we come across high-grade fever, especially in this summer, 104, 105 fevers, and the parents always ask us, fever is so high, why don't you give antibiotic, doctor? What is your take on it, any of you?
So,
this is a 2-year-old child having high-grade fever, so would you investigate this child, but otherwise well-looking?
So, especially in respect to fever, so the grade of fever doesn't correlate with the severity of the infection, first thing. Second, if the child is active, alert during interfebrile interval, so no need to worry. So,
yeah, this child.
Even in viral infections, we get high-grade fever for 3 to 4 days. So we have to see how is the activity and other symptoms of the child, and systemic symptoms, any red flag signs. So we have to counsel the parents that we have to watch the baby closely, hydrate that baby, give antipyretics, but not all high-grade fevers are serious infections.
Yeah, definitely. Very well said. And this child on 5th day developed this kind of rash, and that relieved the pediatrician. So this is a common case we come across. This is Rosella infantum, which has very high grade fevers in the beginning, 104, 105, but the child would be well. So we need to wait and watch. If the rash appears, then we are relieved that we need not have to investigate further. But coming back to this case, Dr. Nirmala, this Asha is continuing to have fever beyond 4 days. But when thorough examination, there is no focus, no respiratory, no GA. So how to go about?
So always you will think about fever with focus and without focus. So whenever there is a focus of infection, you try to manage something like they present with sore throat or ear pain. You know that whether there is acute separated otitis media or pharyngitis or pharyngotonsillitis. But whenever there is a fever without focus, and that too in this child with 4 to 5 days of fever, you would like to go for a complete blood picture. Then when you go for the blood picture and also the smear for MP, and that too fever without focus in the tropical scenario, where you look at presence of are we missing in malaria or dengue type of infections. So you get a CBC done and look at the counts, whether it is leukopenia or whether there is a leukocytosis. Based on that, you try to look also at the platelets. So whether there is thrombocytopenia, in addition to the clinical picture, you would decide whether you go ahead with either dengue or whether there is any significant malaria or prolonged fevers with leukopenia and trick fever.
Most often we come across prescriptions having mefenamic acid. So what is your take on antipyretics in treatment of fever, any of you?
So antipyretics, usually the paracetamol is one of the safest drugs, and there are many antipyretics which are used commonly, ibuprofen, and also sometimes mefenamic acid is mostly used in our state. And so if you look at the paracetamol is a very safe drug and also well established drug, if there is for mild fevers and even more frequently also you can use 4th-hourly based on 10 mg per kg per dose, 10 to 15 mg per kg per dose, 4th-hourly or 6th-hourly. But brufen also for high grade fevers can be used, but mefenamic acid, the recommendation, a scientific recommendation is a very weak recommendation for you as an antipyretic.
Suppose a child with fever has jaundice, some viral hepatitis. So which antipyretic? We are always scared to use paracetamol. So which antipyretic do you use? Any of you can answer.
Still we can use the lower dose of the paracetamol apart from supportive care, and if not subsiding, we can think of other
definitely,
options.
unless there is liver failure, we still paracetamol is safest even in, because in our PG days they used to say use ibuprofen when there is jaundice, but ibuprofen and mefenamic acid is more dangerous because of the coagulation abnormalities present in liver disease. So we are in summer, can you just give a comment on heat related illnesses, because not all fevers are infections.
Especially for neonates, in the first week, the commonest issue is hyperthermia because of environmental temperature. We should see that it is mainly due to inadequate feeding and hyperthermia, rather than if the baby is well thriving, because in environment induced hyperthermia, baby will be active feeding except for the temperature. So this is one of the major problem which we see in neonates.
Especially in units like Gandhi and Nilafar Hospital, where huge number of babies are there,
so
no air conditioned units.
Here the management is giving adequate feeding and removing that high temperature rather than giving paracetamol for these babies.
Well said. Now we will go to another case. This is a 6-year-old child, sick looking, has fever for 5 days. On examination has organomegaly and also some amount of lymphadenopathy. So Dr. Raghupati, how will you go about?
Yeah, first of all, when I see this child for the first time in ER or pediatric intensive care, I'll think of PALS approach, because the child is really sick. So we will go through like the steps: initial impression, primary assessment, secondary assessment. So as per pediatric advanced life support protocol, because we will stabilize airway, breathing, circulation, then we'll assess disability and exposure also. So then we will think whether there is any focus or not. So first we have to stabilize the physiology of the child, like if the child is in shock or not. Then we have to think of the focus. In the focus also, if there is any obvious focus or not, we have to see like any obvious focus or sometimes hidden focus also. We have to think like ASOM, pneumonia, gastroenteritis, UTI, cellulitis or abscess somewhere. So if you don't get any focus, don't directly jump to the laboratory of full of investigations. So we have a habit of going for panels, comprehensive panels like PCR panels for every child, blood, respiratory panels and all. Rather than going for the panels, so we can go for a syndromic approach, which depends upon clinical picture of the child. Like during this season, like especially if you have retroorbital pain, fever, rash, severe abdominal pain, and we will think of like dengue. And if you see a scar with fever, with multi-organ dysfunction, sometimes can present like cases in scrub typhus. And if you see like multi-organ involvement, myalgia, lymphadenopathy, if you see in the background of use of raw milk or even simply using like uncooked this paneer also can cause brucella. Then comes fever, multi-system involvement with joint involvement, then with polyserositis, then we will think of some rheumatological causes. Likewise, syndromic approach we have to do first, then classify grossly which category it belongs to rather than going for a battery of investigations. So if you see a child with fever with encephalopathy, we have to think of common causes first. After doing focus history and examination. So if you have definite evidence of malaria, we will treat with artesunate, then artesunate combination therapy. Scrub typhus, if it is, we will put doxycycline as a drug of choice. If you have encephalitis unclassified, we will start with ceftriaxone, acyclovir together, and then we will narrow down. Then if there is no diagnosis even after basic labs and on focus examination, we can, if this child is really sick, we can put ceftriaxone, some antiviral cover, and so especially if they are residing in an endemic area, we have to give doxycycline and antimalarials as well, and then we have to de-escalate accordingly. If you see a child with multi-organ dysfunction, very, very sick child, then you have to start antibiotics in the ER. First dose of antibiotics should go within 1 hour of admission, and then you think of other like focus and any definitive diagnosis is coming after syndromic approach. If you see dengue, we give supportive care mainly. Enteric fever, the drug of choice is ceftriaxone IV if the child is sick. Malaria, as we discussed, artesunate combination therapy. If there is no diagnosis even after examination and labs, we can, like if the child is really sick, we can put like a cocktail of drugs and then we can de-escalate accordingly.
Yes. So, yeah, very, very well said. And now coming back to our case, these are the preliminary investigations done. Child is continuing to have fever and hemoglobin is 10, WBC is around 12,000 and platelets are 1.1 lakh, CRP is 68. Malaria, dengue, CU are negative. Dengue serology is negative. So what other investigations would you like to do? And on thorough examination, we found to have this lesion.
So here we can see some hidden lesion there. Can someone tell? Like, it is like hidden eschar. So usually eschars, they will happen like in hidden areas like flexural areas and these areas. So we have to definitely send scrub typhus and veil felix if we have facilities.
Positive and turned out to be scrub typhus. And these are all some of the rashes which cases admitted in Nilofer Hospital. Several kinds of rashes can occur, vasculitis, macular, papular rashes. In case of rickettsia, when we were doing postgraduates, we were not seeing so many cases of rickettsia. But of late, we are able to diagnose more and more cases of rickettsia, and promptly, of course, doxia has become so common. Like paracetamol, they are giving any high-grade fever, second day, third day, they are starting off doxycycline. Coming to Dr. Swapna, this is a neonatal, late in the neonatal period, a female baby brought with fever of 4 days duration. Baby was treated outside with antibiotics, but fever was not coming down. So they came to us, and how do you approach this case?
So usually when you take neonates, unlike pediatric children, whenever the child is having fever, better to admit the children in the hospital because these babies, we have to rule out serious bacterial infection, which is one of the common issue which babies can end up. And whenever you have fever for 4 days and you are given antibiotics not responding, we have to think of other causes. Even malaria can occur in neonates, dengue, especially if it's a dengue season, and we also see high-grade fever in chikungunya, so other and urinary tract infections. So all these things we have to take into considerations whenever we have a high-grade fever. And here also we have to see whether there is any focus, skin rashes, any like pediatric children, we also see rashes, dengue rash, chicken pox rash, all those rashes also we have to see and work up. Such babies better to admit the baby in the hospital and manage the baby.
Yes, even a young child, even it is well looking, suppose the child baby is below 2 months, even if the child is well looking, there is a risk of bacterial infection. Earlier we used to say SB, serious bacterial infection, but that term is no longer used. The names like pneumonia, meningitis, septicemia, these are the specific terms used. Earlier there are so many classifications for risk stratification like Roster, Philadelphia, Boston, but all those are obsolete now. The recent classification is based on the AAP clinical practice guidelines released in 2021. So this is the algorithm for 8 to 21 days old baby. As the case is treated by you, I think you can narrate the case better?
So, as this baby had high-grade fever, not responding to antibiotics. Routine case, we sent blood culture, urine culture. But through the course, we saw the baby was irritable, crying, the red rash, flushing, similar of we see in dengue. So, the baby later went into shock, the similar what we see in pediatric. We managed with fluid. Luckily, the baby didn't have any bleeding manifestations. So, with fluid and supportive care, this baby responded, and dengue IgM came positive. So, we see lot of chikungunya and dengue cases even appearing in unit. Vertical, some babies usually present within first 10 days, but postnatal acquired infections present after 10 to 12 days after second week. So these are also high-grade fever. We have to think of malaria, dengue, and septic arthritis, osteomyelitis, all those things. So we have to thoroughly examine the neonates.
How common is fever in neonatal infections?
Usually neonates present with hypothermia. That's what we say whenever there is infection, babies present with hypothermia because they have immature thermal regulatory center, and because of large body surface area, they end up mostly, they will be, sicker babies will usually present with hypothermia, but we also see fevers, especially pneumonia, viral infection, all these present with fever. Otherwise,
Sepsis,
usually
is
sepsis.
it true that gram-positive sepsis has fever rather than hypothermia? Yeah, thank you. I thank panelists for a crisp discussion. So they all helped us in deciphering how to manage the fevers rationally. We need to evaluate them properly and avoid irrational use of antibiotics and unnecessary testing. And we should remember, though there are so many classifications and algorithms, no one size fits all, and we need to individually evaluate every case and manage appropriately. Thank you for patience.
Thank you, madam, and panelists for your excellent talk. On no question, because already we are late. No questions, please. Anyone, you can directly talk to the panelist. Now we go to the last topic of the today's. I request all the delegates, you can have your class and sit in the chairs. Come front and sit. So we have a last talk, that is bone health in the kids by Dr. Srinivas Kotla. He is a associate professor from Nagar Karnool Hospital and also he is a EB member. Please, Srinivas.
Good evening, everyone. Today's my topic is bone health in kids, and I'll be discussing importance of supplementation of vitamin D, calcium, and also some role of vitamin B12 in linear growth. So calcium, phosphorus, and vitamin D, they form a triad for bone health because they contribute to the optimal peak bone mass and are maximum at pediatric stage. And important thing is optimal levels of calcium, phosphorus, and vitamin D are important to prevent osteoporosis in adult. And we all know that 99% of the calcium is present in the bone and 85% of the phosphate is present in the bone as microcrystalline apatite. And low calcium and low or borderline vitamin D will lead to will lead to rickets, and vitamin D is important in maintaining demand and supply of calcium at adolescent growth spurt and at weaning, whenever dietary calcium intake may fall or bone accretion rate may maximize. So next we will be discussing causes of hypocalcemia. Causes of hypocalcemia, particularly nutritional insufficiency, inadequate sun exposure leading to vitamin D deficiency, leading to hypocalcemia, exclusively breastfeeding without any supplementation of calcium and vitamin D, improper feeding techniques, lower socioeconomic status, and malnutrition, and some perinatal risk factors such as birth asphyxia. And another important cause of hypocalcemia include picky eating behavior, which is common in Indian. So Indian settings, 25% of the Indian children have picky eating behavior, and they have lower anthropometric measures when compared to the non-picky eating behavior children, and also they take lower amounts of calcium and other micronutrients. And a study was done in India, Harinarayan et al. So in the study, it was seen that RD of 3/4 of the Indian children consume less than 50% of the calcium, and the most common mineral deficiency in children aged 6 to 11 years is that of calcium. And there are several studies done on vitamin D deficiency, and children and adolescents, the vitamin D deficiency is such common that it is 50% of the children and adolescents have vitamin D deficiency, and if you see in infancy, it goes up to 74%. And a multicentric study was done by Kadlikar, and it showed that 66.4% of the was prevalence of vitamin D deficiency, and the pooled mean serum values were less than 18.57. And we all know the clinical manifestations of hypocalcemia and vitamin D deficiency. So vitamin D deficiency in neonates will present as features of hypocalcemia, that such as tetany, and sometimes very severe vitamin D deficiency can present as florid rickets. In adolescents, it presents as tetany, and osseous manifestations include rickets and osteomalacia. And non-osseous manifestations, particularly symptomatic hypocalcemia, proximal muscle weakness, recurrent infections, and rarely it may cause dilated cardiomyopathy and raised ICP. Clinical manifestations of calcium deficiency in infants, it leads to lethargy, vomiting, poor feeding, and apneic spells. And in other symptoms include of hypocalcemia, perioral numbness, paresthesia of hands and feet, muscle cramps, carpopedal spasm, seizures that can be focal or generalized, and laryngospasm, stridor, wheezing, and cardiac arrhythmias. So management recommendations. So in Indian Academy of Pediatrics in 2017, they have given recommendations of taking vitamin D and calcium both for prevention and treatment. So for prevention, in premature neonates and up to 1 year, it is recommended as 400 international units per day, and from 1 to 18 years, it is 600 international units per day. And for treatment of vitamin D deficiency, for up to 1 month, you can give up to 1000 international units per day, and from 1 month to 12 months, that is in infancy, you can give up to 2000 international units per day, and going after 1 year, it ranges from 3000 to 6000 international units per day. And for hypocalcemia, to prevent hypocalcemia, important thing is in premature neonates, as the transfer of calcium occurs in the last trimester, you have to give vitamin calcium around 150 to 220 mg per kg per day, and you have to supplement along with vitamin D. And in neonates, it is for prevention, it is 200 mg per day, and 1 to 12 months, it is 200 to 500 mg per day, and in 1 to 18 years, it is 600 to 800 mg per day. And for treatment of hypocalcemia, the similar dose of 175 to 200 mg per kg per day is given, and neonates and up to 1 year, you can give up to 500 mg per day, and 1 to 18 years, it is given 600 to 800 mg per day. And this is the latest expert group consensus in India, which has recommended that 0 to 6 years, 400 international units per day is given, and 6 to 12 months, you have to give 400 to 600. It depends on the daily amount of vitamin D consumed with meals. And in healthy children from 1 to 3 years, it is 600 international units per day, and healthy children aged 4 to 10 years, you can go up to maximum of 1000, but it depends on the body weight of the child and the dietary vitamin D intake. And these are the conditions where you have to routinely give vitamin D supplementation. So routine indications include high-risk conditions such as cerebral palsy, neuromuscular disorders, gastrointestinal surgeries, gastrointestinal malabsorption, chronic kidney disease, chronic liver disease, and chronic use of drugs which interfere with the vitamin D metabolism, such as glucocorticoids, anti-epileptics, ketoconazole, and diseases which have extensive cutaneous involvement. In these conditions, there is decreased vitamin D synthesis. That's why you have to routinely give in these conditions. And the important thing of supplementation of calcium is calcium should always be supplemented with phosphorus in a ratio of 2:1. If there is low calcium phosphorus diet, there will be low bone densities and calcium balance will be affected, and there will be increased risk of bone fractures. And this is very underestimated, the role of vitamin B12 on skeletal muscles. So we all know that vitamin B12 deficiencies will occur in these causes such as inborn errors of transport and metabolism, and pernicious anemia, gastrointestinal surgeries, malabsorption, and clinical manifestations can be general, neurological, hematological. General include weakness, fatigue, anorexia, and failure to thrive. And neurological include developmental delay, regression, sometimes seizures, abnormal movements, poor school performance. This can be secondary to anemia. And hematological, we all know it can be macrocytosis, anemia, leukopenia, thrombocytopenia, and hypersegmentation of neutrophils and pancytopenia. And the important thing in linear growth, this is a very important slide. Important thing in linear growth is vitamin B12 will participate in methylation of homocysteine to methionine. If there is any disruption in this cycle, there will be increased homocysteine levels. So increased homocysteine levels will lead to increased reactive oxygen species, leading to altered gene expression associated with skeletal muscle regeneration. And another important reason why it affects skeletal muscle is increased homocysteine will lead to decreased nitric oxide availability, leading to altered skeletal muscle blood flow. And another point where it affects linear growth is the disruption of this cycle will lead to senescence of chondrocytes in the growth plates, thereby leading to limitation of growth plate. And of all the anemias, vitamin B12 deficiency will be seen in 47% of the cases, and more in infancy and in adolescent age group. And management guidelines of vitamin B12 deficiency is, for infants, you have to give 500 micrograms daily, every day for a week, then alternate day for a week, then 2 days for a week, then once a week, followed by once in every 15 days per month, then once a month. And older children, they require 1000 micrograms per day. And children who require parenteral administration include children who have neurological manifestation, underlying malabsorption syndromes, and children who are having severe pancytopenia and disorders of vitamin B12 metabolism. With the neurological manifestations, you have to give for 6 months, and without neurological manifestations, 3 months of vitamin B12 supplementation should be given. And these are the studies done in the recent period, that is for supplementation of calcium and vitamin D. So an RCT was done in Nigeria, where 647 children were included. Of the mean age 15, they were divided into 3 groups. One group was given pharmacological calcium carbonate with vitamin A. The other group was given the dietary calcium in the form of dried fish with vitamin A, and the control group was given 2500 intervention units of vitamin A. So after the 18 months of intervention, they have seen for anthropometric measurements and bone mineral density. And results were, there was increase in bone mineral density and increase in weight for age. Another cohort study done in Australia, where 336 subjects were taken, and age of study, they were started at 18 months of age and followed up to 8 years of age. And interestingly, they found that the children who had taken more amount of calcium had lower systolic blood pressures at 8 years of age, and there was no association with diastolic blood pressure at 8 years of age. And similarly, another study was done in children with type 1 diabetes mellitus, age group of 5 to 23 years of age, and total 203 children were taken, and they were given milk and vitamin D3, one group. Other group was given calcium carbonate with vitamin D3, and the other group was control group. And the outcome was measured in view of bone parameters, that is bone mineral density and bone mineral content, and increase in percentage of cortical thickness. So in this study, the supplementation of milk or pharmacological calcium improved bone outcomes, particularly geometry in children with type 1 diabetes mellitus, with more pronounced effect in girls. So another study was done in calcium supplementation among premenarchal girls in India. So this is a double-blind control study. So In this, 214 premenarchal girls were taken of 8 to 12 years, and they were given, one group was given calcium, other group was given calcium with multivitamin with zinc, and the other group was the control group. And they have measured their again bone mineral density and bone mineral content. Was post supplementation, you can see the calcium group had higher bone mineral density when compared to calcium and multivitamin and zinc group when compared with control group. And the clinical evidence for vitamin B12 supplementation include, there was one study which is double-blinded RCT study done on 1,000 children from age 6 months to 30 months. In that study, one group was given folic acid double the RDA, second group was given double the RDA of vitamin B12, third group was given both vitamin B12 and folic acid, the fourth group was the control group. And they followed up to 6 years of age. What they found out is children who received vitamin B12 were having higher mean weight for age, and also weight for age Z-scores and height for age Z-scores increased significantly after vitamin B12 deficiency in malnourished children. And this is the last study, the recent study where vitamin B12 supplementation was done to assess the developmental assessment. In this study, again it is a RCT study of which 422 children were taken from 6 months to 30 months. They were also given folic acid double the RDA and vitamin B12 double the RDA, and both folic acid and vitamin B12 and a placebo. So the outcome was measured based on the ages and stages questionnaire, that is developmental assessment. So the total ASQ3 score was found to be higher compared to those who received placebo, and higher scales were seen in gross motor milestones, gross motor subscale, and problem solving subscale. Group receiving vitamin B12 had higher scores of gross motor scale, 4 points higher than the placebo scale. So this study was done in North India. So they concluded that supplementation of vitamin B12 and folic acid benefit neurodevelopmental in North Indian children. So these all studies emphasize that there is a role of calcium and vitamin B12 and vitamin D supplementation in infants and children. Thank you.
We have come to the last session. We will conclude in another 5 minutes. So we have a very important announcement. So from TCB IAP, we are releasing our bi-monthly journal, PD News. So we have usually this is to be getting a March, but due to logistic reasons, we could not do it. We are releasing the first, and in next 5 to 10 days, you will be getting the second issue also. The most important thing here is in this PD News, we are putting a quiz corner wherein quiz questions are given. The answers first and second and first come first basis from today within next 3 days will be awarded first and second prize, and all the first 10 answers will be published. Their names will be published in the next issue. So for this, I request the editor-in-chief, Dr. Tilak Chandrapal sir, today's guest, Dr. Atanu Badra, and all my EB members, secretary, treasurer, and editorial team, Dr. Usha Rani, Dr. Nirmala, Dr. Kotesh, Chandramohan, all the editorial team, Vamshi, I request and central EB member, Dr. Rashekar, I request and PAT's president and secretary to please come on to the dais for launching of the first edition of the PD News. Sir, come. Our guest, sir, and I request everybody to come. So now I will be sending the soft copy of the same, wherein you have all the questions. So the questions time will be 5 p.m. of the 2nd June. We are given 3 days. It will be sent to the only mail which is provided. Other than that, the answers will not be considered. Thank you. Sir, your comment.
We are very glad that though it is late, it was released today. And I hope you will enjoy the quiz and other articles given in the Pedi News. All of you participate in the quiz. Thank you.
I request Dr. Atanu to say a few words.
Online. It looks very attractive. And thanks to the team who had done the hard work, because I know it's always a very lot of work goes into making a small magazine. And this, I think this is the bi-monthly. How do you manage to do the bi-monthly? Even getting one per year is difficult. Every 2 months, one issue, I think it's really, really, I think we'll need all your help in designing something, because you're all now experts in Pedi News publications. Thank you, Twin City branch.
I want to tell, the cover design is done by me. I request another associate editor, Dr. Usharan.
Congratulations to all the editorial committee members and also president. This is all the initiative, I must say, this is all the initiative of Dr. Ramesh Dampuri, and who has coordinated, and day in and day out he's been striving hard to streamline the things. And also I congratulate all the editorial board members and all the authors who have contributed articles, and also Dr. Tilak sir, who has led the team effectively, and we could bring out this journal on this day. Thank you.
We will conclude in another 2 minutes. We have 2 announcements. First one is I want to let you know IAP TCB is having its 32nd annual conference along with the National Pediatric Dermatology Conference on September 26th and 27th of this year. And shortly, maybe by next week, we will be releasing the registration and everything. I request everyone to please participate and register yourself. And now I think Sridhar wants to make another announcement.
Central Zone PEDICON having 5 states. Telangana is hosting. So this is hosted, the conference will be hosting at Warangal. So the conference is on August 28, 29, 30th. So kindly register for that conference and make it a grand success. And my president, Vijay Kumar sir, please say one word.
Anish, come here. Come here. Those who want to register right now, the boy is available. Please have you registered.
Anish is available.
Anish is available. Anish boy is available. Please register.
Discount will registration.
There is a special discount for next 3 days. Today, tomorrow. There is a special discount also. 1100 తక్కువ. Sir.
1100 only 1200 ఇవ్వాలా ఇప్పుడు సరిపోతుందా? Okay. Now I request our treasurer Srikanth to propose vote of thanks.
Thank you, sir. Good evening, everyone. I thank all the, first of all, I thank on behalf of IAP TCB and the PEDICON 2025 team and 2026 team for such a wonderful session today evening. I thank specially Dr. Atanu Badra sir and Dr. Kripa Sindhu Chatterjee sir, and also all the members of IAP TCB and senior members of IAP TCB. Thank you for coming all over here and having a good academic feast along with the memories of 2025 PEDICON and 2026 PEDICON. Thank you one and all. Have your dinner and the fellowship. Thank you one and all.